Welcome, everyone. Thanks for joining us tonight. Please stand by for just a couple of minutes. We'll allow everyone to join in, and we will begin shortly. Good evening, everyone. Thank you for joining our Men's Health webinar. I'm Ryan. I'll be your host and moderator. We'll start with a few housekeeping items, then I'll introduce our speaker. First, your attendance tonight is completely anonymous to the other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speaker. If you wish to ask a question, please type it in the chat box at the lower part of your screen, and we'll be sure to include them during the Q&A session after the presentation. Our presentation tonight will last for approximately 1 hour and be presented by Dr. Benjamin Martin. Dr. Martin joined Urology of Indiana in 2011. He's a graduate of Miami University in Oxford, Ohio, where he graduated cum laude with a BS in Computer Systems Analysis. He earned his medical degree from the University of Cincinnati College of Medicine in Cincinnati, Ohio, completed his general surgery internship, as well as his urology residency at the University of Alabama at Birmingham. Dr. Martin, thanks for joining us tonight. I'm going to go ahead and turn it over to you.
Thanks, Ryan. Thanks, everybody, for joining us. It's nice to meet without a mask and talk, even though it's not face-to-face. It feels good to have no mask on. Tonight, we're going to talk about BPH. As Ryan said, I'm with Urology of Indiana, which is a large urology group here in Indianapolis and surrounding counties. I have 20 plus partners, and several of us specialize in the care of BPH. And thanks for taking the time tonight to learn a little bit more about this disease. So we'll skip ahead. Like I said, here at Urology of Indiana, I practice at several hospitals, Community North, and have offices in Noblesville and in the Fishers area. So tonight we're going to talk about several things all around the topic of BPH. And BPH is our fancy term for what stands for benign prostate hyperplasia, which is simply just fancy terms for an enlarged prostate. So we'll talk about what a prostate is, we'll talk about what BPH is as a disease, and then we'll talk about different options, both medical and surgical, for the treatment of BPH. So what is a prostate? A lot of guys don't know what a prostate is. Only men have prostates. Women do not have prostates. If you look on this cartoon, I'm not sure if you can see my pointer, but you can see the bladder, which is labeled. And then you have an area here, which is the prostate. The prostate is part of our sexual function. It produces the fluid that comes out with ejaculation. Like I said, it's a male-specific organ. Women do not have it. There are different conditions that affect the prostate as men get older. We just talked about BPH, which is the enlargement of the prostate. There's also a condition called prostatitis, which some men will experience. It's generally thought of as an inflammatory process or inflammation of the prostate. And then there is obviously prostate cancer, which a lot of us have heard about. Prostate cancer is common as we all get older. Prostate cancer, BPH, and prostatitis are all different examples of diseases that can occur to men with their prostate, and oftentimes have a lot of similar symptoms. So my job in urology and my colleague's job is to help differentiate, do you have prostatitis, do you have prostate cancer, or do you have BPH? And there's different ways that we get to that goal. So let's talk about BPH as a disease. Like I said, BPH stands for benign prostate hypertrophy. And if you break down those words, what you're getting is benign, meaning non-cancerous, prostate, meaning related to the prostate gland, and hypertrophy is just the fancy medical term for too many cells or increased volume of cells, so just too much tissue, so too much prostate tissue. It's the fancy term for an enlarged prostate. BPH is oftentimes patients come to us and they're trying to figure out, do they have prostate cancer or do they have an enlarged prostate? And there are some overlaps. BPH in and of itself is not prostate cancer. BPH does not cause prostate cancer, but there are some overlapping symptoms. So we'll talk about some of those symptoms, but classically you'll hear people say, I have a decreased stream, I'm going to the bathroom too often, I'm going to the bathroom at night. Prostate cancer in some men have similar symptoms. So the anxiety we understand on, do I have prostate cancer or do I have BPH? We will help patients work through that. PSA is a blood test that we often use to help distinguish whether or not someone has prostate cancer or a BPH. PSA is a tool. It's not the absolute end all and be all in making that decision, but it is a helpful tool in helping us discern who has prostate cancer versus BPH. So oftentimes we talk about normal versus an enlarged prostate. Most men, when they're in their 20s or 30s, we say usually have what we call a 20 or 30 gram prostate. And if you look at the cartoon on the left, you see this smaller prostate, you see the bladder, and you see some arrows showing the urinary flow through the prostate as it travels down through the urethra. And as a young man with a smaller prostate, most of us remember having good flow, not going at night, and being fairly satisfied with how we urinate. As men get older, their prostate in some men, and a lot of men, their prostate will enlarge. And that's that cartoon to the right. That shows an enlarged prostate where the bladder is having to work harder and harder to push that urine through the prostate. And that oftentimes results in a slower stream, going more often at night, or a sensation of incomplete bladder emptying, all of which are signs of potentially that enlarged prostate. So the symptoms of BPH there's numerous ones. You don't have to have them all. You can only have sometimes, some unlucky guys have them all. Some guys just have a couple of them. Most of the time we think of a weak stream. We have to talk about an inability or a struggle to start your stream or a pushing to start your stream. We'll also talk about a urinary hesitancy, which is that start and stop where you're going and then you stop, then you go some more and then you stop again. Sudden urge to urinate, that sensation of not being able to put off urination. All these symptoms, and there's probably about 10 of them, can be related to BPH. They don't always have to be all BPH symptoms, but these are some things that we at Urology of Indiana will ask and try to tease out of you at a visit, trying to figure out what your urinary symptoms are. How common is BPH? BPH is quite common. 49% of patients experience sexual problems with BPH, and most men are unhappy with their urinary symptoms if they do have BPH. Here's a slide that talks about how common it is. 50% of men by age 60 will have some signs of BPH. 90% of men by age 85. So if you're lucky enough to live into your 80s and beyond, you unfortunately probably will be rewarded with some degree of BPH. So this is a large disease within the population. It is one we see frequently and commonly. In a given clinic day, I'll probably see 10 to 12 patients that come in with symptoms of BPH, and our job is to work and try to improve those symptoms for those men. So when you come and see us, how do we diagnose an enlarged prostate? It's usually like this. We're going to talk about symptoms. We're going to ask those symptoms. Do you have a weak stream? Are you going at night? Do you have that hesitancy where your stream starts and stops? Most of the time, we're going to perform a rectal exam. It's not my favorite. I know it's not your favorite, but there's a lot of good information that comes from that. Then we're going to ask you some quizzes. It's almost like being at school. When you're sitting in my lobby, you're likely going to be answering some questions asking about how frequently do you go? Can you postpone urination? All these help us quantify how much urinary symptoms you have. Oftentimes we'll ask you to do some tests where you urinate and we're measuring your flow. There's different tests we do in the office to help us differentiate how bad the BPH potentially is. So that's what you can expect. Physical exam, a discussion with a physician, and likely some questionnaires that really help us figure out what you're experiencing day in and day out at home. So then when we're sitting across from you, we're going to start talking about treatment options and how we can potentially help you to urinate better. Really, in our mind, as we're sitting there, we're thinking almost on what we call a continuum, from very unaggressive or not very invasive procedures all the way up to more invasive procedures. And that's what this slide is trying to depict. If you look on the left in the green, there's stuff we call behavioral modification, which a lot of patients have already done. They're limiting their fluid intake. They're changing their diet. They're trying to do certain exercises, trying to improve their prostate health. Most of the time, by the time you're seeing a urologist, that might be too much or too little too late. Then we have what we call first line therapies, which can be medication, which can be office-based procedures. And then we have, to the right of the screen, more invasive procedures. And more invasive doesn't mean bad or scary. It just means more involved in something done in the office. And there's a lot of great procedures in that area, things called TURPs, green light procedures, and what's called a prostatectomy. And we'll discuss each of these tonight so you have a better understanding. But when we look at a patient and we're talking to a patient, we're starting usually on the left side of the screen and moving to the right, trying to find some improvement from least invasive moving up as patients have tried and failed potentially multiple therapies. I will make one statement here about behavioral modification in fluid and diet change. This is something I talk to my patients about routinely, and I find most patients have never heard of this. And there's a lot of potential for improvement in quality of life if you understand this idea of dietary irritants. There's a lot of things we eat and drink in a given day that our bladders and our prostates don't love. I always tell patients it's usually the good things in life. So think caffeine, alcohol, spicy food, things that are high in acidity. These things tend to irritate the bladder and cause a lot of urinary symptoms. If you've got BPH, it'll make those symptoms worse. If you don't have BPH, even if you're a female, these dietary irritants oftentimes make life and urination harder. So I often tell patients doing a little bit of reading, typing into Google dietary urinary irritants can be helpful. Some patients find that they're on way too much caffeine, and if they can reduce their caffeine, all of a sudden they're going to the bathroom less often. So one of the first things a urologist is likely going to bring up or want to at least talk to you about is this idea of dietary irritants. And if you're on this call with me on a Tuesday night at 6 o'clock, you might as well go ahead and take the first step and do a little bit of reading and understanding of dietary irritants and save yourself that at least first little bit of information we're going to pass on to you. This slide just makes a point that there's multiple things that people will see on TV regarding things like super beta prostate and saw palmetto. I oftentimes tell patients that those are fine. I don't really necessarily recommend them. I often tell patients that it likely doesn't hurt, but it's probably not going to make things significantly better. And I always tell patients just don't spend a lot of money on it. If you're sitting at home at night and watching an infomercial at 11 o'clock and someone wants you to pull out your credit card and call them, it's a little bit dubious on how well that usually works. So most of those medications, specifically saw palmetto, have been around a long time. And some patients do get a little bit of symptom relief with it, but just don't spend a lot of money on it and seek consultation with the urologist or your doctor before initiating those therapies. So now we're going to have a couple of slides talking about various treatment options. And just think back to that slide from green to red, left to right on kind of more invasive treatments. And this describes kind of what we're thinking. So we're going to start with watchful waiting. And watchful waiting is just basically saying, my symptoms are slightly bothersome, but I don't want to do anything yet. So that usually means I don't want to start medication. I don't want to consider a procedure. I'm going to work on reducing my caffeine intake. I'm going to try to limit my liquids after 5 o'clock. And I'm just going to see how I do. with trying to modify my behavior. It's cheap, it's free, it's easy to do, and a lot of patients have already done it by the time they come and see us. So it is a treatment. You definitely can be on watchful waiting. Probably if you're on this chat, you probably are already doing some of this. It's very low risk. It just tends not to be successful long term. That takes us to the next step, which is usually medication. So there's two big types of medication that urologists are usually thinking about when they're talking to men with BPH. And the first one is called alpha blocker therapy. Most people know it by the brand name, which is Flomax. Flomax is the brand name for a drug some people have heard as tamsulosin. Tamsulosin is generic for Flomax. It's been around a long time, at least 15, 20 years now. It's by far the #1 drug in urology and has been for decades. Flomax and drugs like it try to relax, and I always make this maneuver in clinic. It doesn't translate well in a webinar, but we usually say it tries to relax or open up the prostate tissue. In a lot of men, it can be helpful, and it's usually the first thing that's tried. Most of my patients have already seen or tried Flomax by the time they're seeing me in urology, and that's because primary care has usually tried them on it, and they've either found it to be helpful or not helpful. Flomax and drugs like Flomax do come along with some side effects. Ones we talk about are usually dizziness or the sensation that the room is spinning when they get up quickly. That's because this drug can lower your blood pressure some, which for most men isn't a problem, but for some it can push them over the edge and they're dizzy. They can be lethargic. Sometimes it doesn't interact well with other drugs they're on. A lot of men tolerate Flomax just fine. For others, it's a no-go. They have side effects and don't like it. The other problem, or not problem, but thing that some people will notice is that it can change their sexual function. And there's a term we lovingly call retrograde ejaculation, which just means that Flomax, through that relaxing process or relaxing of the prostate, causes less fluid to come out with ejaculation. Some men could care less, others care quite a bit. It's obviously a personal conversation. For some men, they dislike Flomax because of that reason. So that's alpha blocker therapy, or what I would call Flomax therapy. There's another form of drug therapy that some men have tried. It's not as common as Flomax, and that's called 5-alpha reductase inhibitors. Once again, a fancy term for what's usually referred to as finasteride or Proscar or Avodart. These are some of the terms that people are familiar with. Those are, once again, old drugs that are been used for decades that shrink the prostate through a hormonal change. It basically blocks testosterone from stimulating the prostate, and that causes the prostate to shrink. The shrinkage doesn't happen overnight. Usually we tell patients it takes several months for that shrinkage to occur, but oftentimes patients will see an improvement in urinary flow and urinary symptoms with being on a drug like finasteride or Proscar. There can be some side effects. Usually it's fairly well tolerated. They don't have problems with the blood pressure or dizziness issue, but it can cause some hormonal changes that patients don't care for. The ones that we typically talk about are decrease in libido or sex drive. And then the other can be what we call gynecomastia, which is our fancy term for breast enlargement. Once again, driven through a hormone change in men. Gynecomastia usually is reversible if they come off the drug, but that can be anxiety provoking for a patient just worried about that side effect. And sometimes men will not start it because of that issue. So we've now left watchful waiting, which is just waiting to see if things get better. We've talked about drug therapy, and now we're starting to talk about the procedures. And there's several, and we'll discuss them all. The first one we're going to talk about is Resume. We will spend some time tonight in more detail talking about Resume. Resume is basically a therapy that's done in the office. It is a minimally invasive therapy. And it uses basically steam energy or thermal energy to kill prostate cancer, and then the body reabsorbs that tissue to open up the channel. One thing you'll hear over and over tonight is basically we have to do something for most patients to open up the channel to get them to urinate better. There are different techniques, there are different procedures, all with the same goal of trying to find some way to open up that channel, either through chemical means like Flomax or with thermal means like Resume, where they're going to use thermal energy to cause some reabsorption for that tissue to open up. So that's going to be a reoccurring theme, is how can the urologist help the patient by opening up that channel to get better urination. We'll talk more about Resume as we go, but this is the introduction to it. It doesn't require anesthesia. There's no permanent implant. We're not leaving anything inside the patient. And then we talk about retreatment rates. Once we get to talking about procedures, it's always about how durable is this? Does it last 1 year? Does it last 5 years? Does it last 10 years? Nothing with BPH is permanent and lasts forever. There's always the potential where that tissue is going to grow back and you might need retreatment at 5 years, at 10 years. And we monitor patients for that and help you make decisions. But the retreatment rate with Resume at 5 years is 4.4%. It's pretty good. 96% of patients didn't require retreatment, which is a pretty good standard when you're talking about surgical therapies. So this is more about Resume. If we looked at the cartoons on the left, you see this enlarged prostate here, and this gray tissue here in the central area is a depiction of what they're showing to be BPH tissue. And then after the treatment, they're showing you that that channel is more open. And so what we're trying to do with Resume is we're trying to open up this channel. If you bear with us, we're going to have a 2-minute video. It worked when we tried it without you guys before you guys got on. So hopefully it works and you can hear it. If you can't, just hold on 2 minutes and I'll start talking again and let you know what you might have missed. But here is the video on more about Resume.
Resume water vapor therapy is a non-surgical treatment for BPH. Resume uses the natural energy found in steam to shrink the prostate. In just seconds, this precise technology destroys enlarged prostate tissue while minimizing any effect on surrounding tissue. Resume is a potential alternative to drug therapy, permanent implants, and surgery. It preserves sexual and urinary functions, and it's clinically proven to safely and effectively reduce BPH symptoms. Potential side effects include painful urination, blood in the urine or semen, pelvic pain, and urinary frequency, retention, or urgency. The procedure is performed right in your doctor's office or outpatient center. You do not need general anesthesia for the procedure, and Resume therapy lets you quickly return to normal activities. Talk to your doctor about Resume if you're no longer comfortable with your BPH symptoms. Drug therapy isn't working for you. The side effects from drugs are impacting your quality of life, or you don't want to have surgery or get an implant.
So hopefully you guys saw that. I think that's a nice depiction in cartoon form of what Resume is. Resume is done in the office. In my office, it's done with patients are awake. We call it with nitrous therapy. Think about being at the dentist where you might have had gas before. I use gas in my practice to make patients comfortable. It usually takes 2 to 3 minutes. It involves a small scope that we put in to inject that steam. And then patients go home shortly thereafter. And the total visit time is pretty brief. We'll talk more about Resume, but that gives you an initial characterization of Resume therapy. Next slide here. When we talk about, oh, here we get another video here, so let me pause it before I get started. Okay, so patient satisfaction is important. We don't want to do anything to patients and not have a decent chance of making them satisfied and helping them out. And Resume has a good track record. And you talk to patients who've had Resume, 97% of them would recommend this to a friend, which is usually high praise when it comes to a medical procedure. So we'll let Joe here tell us about it for the next couple of minutes and see if this video works.
I found out that I had BPH. My symptoms were a slow stream, and I would wake up frequently in the middle of the night. I first heard of Resume when I was researching enlarged prostate and the procedures to repair it, to fix it. And Resume was one of them. The more I researched Resume, it was the latest and greatest technology, and I want to be part of new technology. I think technology is good. My experience with the Resume procedure was very good. After the procedure, I was a little worn, a little tired, and the next day I felt fairly good and was able to get up and get around.
Since Joe's Resume procedure, we're able to spend much more quality time together, fewer interruptions, and we're just happier as a couple. The Resume treatment has made a very big difference in our life.
So I think that patient testimonial reminds me of a couple things. One is it just reminds me that it's always nice if you bring your significant other or spouse to your visit. I can oftentimes tell how bad somebody's symptoms are just by looking at their spouse when the patient's talking. This is obviously affects men, but it affects relationships and how patients are constantly potentially going to the bathroom and they're not being able to do things they want or love because of this disease and the interruption in everyday life. So I would, this is just a side note, but if your spouse is available and you're coming to see us, please bring them. I think two sets of ears are always better than one. And oftentimes I can see in the spouse's face how bad the symptoms truly are when they're shaking their head about, is he going a lot at night? Oh yeah, he's going a lot at night. Can he make it through a movie? Oh, he can't make it through a movie. So we're always happy to have your spouse or loved ones there with you at Urology of Indiana. I think it adds to the clinic visit. So now we're going to talk about beyond Resume. Another minimally invasive technique that a lot of patients have heard about is what it's labeled here, prostatic urethral lift. A lot of patients will have heard about it or seen a commercial for a procedure called UroLift. UroLift is a procedure that's been done now for about 4 years in the United States. It's a minimally invasive approach, oftentimes done in the office. And once again, we talk about the idea of opening or somehow expanding that channel. This one does it through implants. When we do this in the office, we're putting in implants to tack or pull open that prostatic tissue. So we're not removing it in any way, we're just pulling it open. This was done in Australia for a while. It's still done in Australia. And now it's been brought to the United States. It doesn't, you can see in the bottom left, doesn't require general anesthesia, typically done in the office, in my hands and my partner's hands, often done with that nitrous sedation, which is similar to the dentist. It does put in an implant. There is a kind of a new piece of material that's going to be in you most likely forever, holding that prostate tissue open. The retreatment rate is higher than Resume. If you look at their data for 5 years, you're looking at a 13.6 chance that you might need another procedure beyond a UroLift, where it was closer to 4 with Resume, so a little higher retreatment rate. But for the right patient and the right prostate, this can be an acceptable procedure. And that's most people would know that as UroLift. Then moving beyond what I would call office procedures. So office procedures, at least in my world, in my practice, is Resume and UroLift. Now we're moving into procedures that are done in a surgery center or sometimes a hospital. And you can see in the bottom left, it requires general anesthesia. So this is a procedure called a green light. I've done hundreds upon hundreds of green lights. It is one of the most popular BPH procedures in the country. And it is the modern day version of a procedure called a TURP. And a TURP is an acronym, it's TURP. And TURPs have been around for 30 plus years. And basically what these procedures are procedures where the patient's asleep, no cuts, no incisions. With the patient asleep, we bring a small scope in through the penis into the prostate, and we use a laser to core out the prostate. We're not removing it. This is not a prostate cancer surgery. This is like coring out an apple, where you go in and you just remove and open up that tissue within the channel to allow the guy to urinate better. It takes about 45 minutes to an hour. Patients almost certainly, not always, but most of the time, 90+% of the time, will go home that same day. The retreatment rate with this is low. Once again, similar to Resume at 4.8 over 5 years, and tends to have a pretty good durability, meaning still having good results 8 to 10 years after the procedure itself. So green light is using a laser to remove tissue, and I tell patients it's a modern day version of what's called a TURP. And the next slide is about a TURP. Oh, no, it's not. Must be the following slide. So this is more information on a green light. Same cartoon showing that gray tissue here being BPH tissue, and then afterwards that channel being opened up. And we can watch a little video here about green light therapy. So that video obviously didn't have commentary, but what you saw was a patient asleep in a surgery center. That was me sitting between their legs with a small scope, bringing a scope in, and then that little laser fiber comes out of the scope, and that green light is laser energy that burns away prostate tissue. So that laser is sitting there sweeping across the prostate, and as it sweeps across the prostate, it is burning and bubbling away prostate tissue, all with that goal of opening up that channel. And if you were to pay attention to the video, towards the end, you saw kind of a prostate with a nice wide open channel, and that's the goal. We're trying to get a nice wide open channel through that prostate so the urine flows, the bladder empties better, and the patient has more of a better stream. So that's what a green light procedure is. And then another procedure, and some of my partners perform TURPs. TURPs have been around the longest, and it kind of depends on the generation of the urologist. I'm in my early 40s. I've done a ton of green lights. I've done a handful of TURPs. I have partners that are in their 60s that have done thousands of TURPs. So all of these are good procedures, but they're just trying to get to the same goal through different means. So a TURP was the original way of performing that procedure, similar to a green light, where instead of using a laser, they bring in a small scope and they use a wire that basically gets superheated to cut away tissue. So they're kind of taking out little pieces of tissue, and the tissue floats away, and then they retrieve it and pull it out of the bladder. And that's been done for a long time. And a lot of patients have memories of their dads or brothers getting these procedures called TURPs or Roto-Rooters done years ago, even decades ago. And they were good procedures. They got good results. The downside to a TURP was typically it was what we would call a bloody procedure, so tends to have more blood loss, longer need for a catheter after a procedure. And sometimes patients were in hospitals for several days. They were comfortable. They were just waiting for the bleeding to stop. And that's the big difference between a TURP and what I call a modern day TURP, which is a green light. A TURP and a green light patient at the end of the day, both typically have the same open cavity in their prostate. The laser just allows less bleeding, quicker recovery, lesser need of a catheter. And then the big one is they get to go home the same day. Most patients who have TURPs oftentimes will stay a day, maybe a day or two in the hospital. A green light patient, in my hands, typically 90+% of them are going to go home the same day. This one is important, but not too often encountered. This is called a prostatectomy, or what's called a simple prostatectomy. Prostatectomy is our term for removal of the prostate. I also remove prostates for prostate cancer. That's done through what we call a robotic approach, which is a form of laparoscopic surgery. There are some times where a patient's prostate is so big, where it's so large, that Resume, Urolift, green light, TURPs, they're just not, it's too much. There's too much tissue. We can't core and open up because there's just too much tissue in that really large prostate. And there are some scenarios where we will recommend going in surgically or laparoscopically and doing what's called a prostatectomy. We don't take the whole prostate out like we do for prostate cancer, but we basically core it out with surgical techniques that we can use with a laparoscopic approach. This is not a common thing that people have to think about or to consider. We will help guide you through that. If you have a really large prostate, we will have specific recommendations that are unique to your circumstance. Most patients with run-of-the-mill BPH don't typically have to consider robotic or simple type of prostatectomy type procedures, but we put it in here for completion so you guys have an understanding of kind of everything that's potentially available. Insurance coverage. Not sure if there's a slide on this. Yeah, insurance coverage is usually, most of these procedures are almost, in today's day and age in 2021, most of these are covered. Green light, Urolift, Resume, TURPs, these are within the main lane of modern medicine, and most insurance coverage is going to cover them. I can tell you off the top of my head, Medicare, which, let's be honest, most men who are having this problem are often 65 and older. Medicare covers all of these. We can talk about cost considerations. Some of these are less expensive and some are more expensive. We're well equipped to have that conversation with you. But from an insurance coverage, is it covered point of view, if you have Medicare, the answer is almost certainly yes. And if you have private insurance, the answer is almost certainly yes. But we're going to look into that for you and do what's called a prior auth, where we confirm that you do have insurance coverage, so there's no surprises. And that leads us to next steps. Most of patients have general practitioners or primary care docs, and they're doing a great job trying to help you with your BPH. They might have started you on Flomax, possibly on finasteride. I would suggest, if you're on a webinar talking to a urologist and on a Tuesday night, you probably should come and see a urologist and talk to us face to face. We're more than happy to talk about these issues, talk about your situation, and talk about specifics that would be beneficial to you. Most of the time, we're tailoring our treatments. Most of us do all these treatments, and we're trying to find the right treatment for you that makes sense for what your goals are as far as trying to improve how you urinate and what your expectations are. Do you want to avoid general anesthesia? Do you not care about general anesthesia? How much time do you have for recovery? How big is your prostate? All these things we're going to help tailor to your situation. So myself, my partners at Urology of Indiana are here and have been for decades, waiting to see you, and would be happy to talk to you further about these issues. At this point, I think Ryan's going to jump back on and hopefully we have some questions and can give you guys some more